Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for tonight's program on diabetes. We'll be glad to take your questions on diagnosis, complications, and treatment of diabetes. The success of this program is very dependent on you, the viewer, so please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Gail Baldwin, a family physician with the Twin Ports VA Outpatient Clinic in Superior, Dr. Deborah Walston, an internal medicine specialist with St. Luke's Duluth Internal Medicine Associates, and Dr. Stephen Teacup, a family physician with the Gateway Family Health Clinic in Moose Lake. Our medical students answering the phones tonight are Danielle Levasseur from Ogama, Minnesota, Jessica Olin of Mora, Minnesota, and Isaac Zoller from Park Rapids, Minnesota. And now on to tonight's program on diabetes. So while we're waiting for questions, we have a few questions we've prepared. And so Dr. Ralston, we'll probably kick off with this one about the different types of diabetes.
Yeah, I think this is a really important question, Dr. Westra, because a lot of us have heard the terms insulin dependent and non-insulin dependent, and those terms are a little bit antiquated. We now use the terms type 1 and type 2. And to understand the difference, we really need to know what diabetes is. When we eat a meal, spaghetti for example, the food that we eat is turned into sugar in our blood. And for our body to use that sugar, our muscles to get the energy, you need insulin to allow that sugar to get into our blood cells. In type 1 diabetes, which is typically the diabetes that adolescents or young adults get, our bodies just stop producing insulin. For some reason, our immune system attacks the pancreas, which is the organ that makes insulin, and we just don't have any insulin. When that happens, the sugar builds up in our bloodstream and our glucose levels get very high and we get very sick. And to treat that, we need to give ourselves insulin injections in order to allow us to absorb that sugar. Type 2 diabetes is different. We still make insulin, our pancreas still functions, but for some reason, our bodies become a little bit immune to the insulin, or it's harder for the sugar to get absorbed into our blood cells. And in that case, the best things that we can do are sometimes to lose weight if we are overweight, which is not always the case. Sometimes take pills, watch how we live our life. So two very different diseases. They share a name, but really the underlying physiology, the underlying reason for the diabetes is very different. The only real connection that they have is that both cause high blood sugar levels and both can lead to complications if they're not treated.
Oh, thank you, that was very helpful. So Dr. Baldwin, how do I know if I have diabetes? Do I have pain? Do I have symptoms?
Well, sadly, usually diabetes, well, maybe not so sadly, but it doesn't usually come with symptoms at first, or they're very subtle symptoms like having extra strong appetite called polyphagia, or extra urination called polyuria, or extra thirst, polydipsia. And so those are the main symptoms there that we look for when we're looking for symptoms of diabetes. But in general, it's often a very symptomless disease, and so screening, particularly of adults, checking a blood sugar once in a while during regular exams is really important to screen it and catch it while it's early enough that it's usually controllable with diet and exercise.
Yeah. Dr. Teacup, a question about how do I reduce the risk of developing diabetes?
I think the risk of developing diabetes, there's lots of aspects to that. There's always the genetics. If there's family history of diabetes, either type 1 or type 2, there is an increase in the risk of developing it. Other things are just selecting the right types of foods, staying on fruits and vegetables, staying away from junk food, and excessive weight is real important to reduce your risk. You have to look at several different things at once when you're trying to stratify your risk for diabetes, and that usually is best discussed with your doctor, and should be done regularly. It's becoming an epidemic in America, and it's something that we spend a lot of time in the office going over. Diabetes is generally considered a silent disease, but there's some clear risk factors for it, including being overweight and, like I mentioned, the family history, and certain medicines that you take can put you at increased risk. We look at all of that when we stratify our patients.
And again, these are reducing the risk of type 2 diabetes. We really don't have any way to reduce the risk of the type 1 or the adolescent onset diabetes. We don't know that yet.
Yeah, we don't really have anything. Well, Dr. Baldwin, what about hemoglobin A1C? I already have about 3 callers asking about that. One is asking if 10.7, we'll give a number, is significant, and then maybe just a little bit about hemoglobin A1C.
I would say 10.7 is a significantly high number. Almost without a doubt, 10.7 means you have diabetes, but diabetes isn't usually diagnosed with an A1C, but it is how we track what progress you're making. I tell people that diabetes A1C values give me an idea what their average is running over the past 3 months, because it's a measurement of how the glucose molecule attaches to the blood cells in a way that can be measured. And blood cells sort of turn over about every 3 months, so that's how we call that an average over the last 3 months. It would be really nice if A1Cs of 10 told you that you're running around 300 of blood sugar. And so having an A1C that said 300 would give you a better idea what your average was going to be. But I think that A1C is a tool we use to track how well you're able to control your diabetes.
Well, we kind of talked about this a little bit earlier too. Pre-diabetes, I do have 3 or 4 callers asking about that. And what fasting glucose number is considered pre-diabetic, and is there such a thing, Dr. Ralston?
There absolutely is such a thing, and it's really nice to catch it when we're in that pre-diabetes range. There's a lot of terms people use: borderline diabetes, pre-diabetes. Medically, we use things like impaired glucose tolerance, and what it really means is that your body is not responding appropriately and that you are at very high risk for developing diabetes. And that's really important, because at that stage, and again, we're talking about type 2 diabetes here, but at that stage, there's really a lot that we can do to prevent diabetes and its complications. So typically a fasting glucose that's between 100 and 126, I would put in the pre-diabetes range. And I do like that word better than borderline, because borderline doesn't say much. Pre-diabetes means there's a good chance you're going to end up diabetic unless you make some significant changes. So I think it's a good term. We also, an A1C of 6 to 6.5, I generally classify, if you know those numbers, I generally classify as pre-diabetes as well.
And with the OB patients is another area, gestational diabetes in OBs. That's diabetes that occurs generally during the gestation. But it's a clear indicator that those patients, the majority of them, would develop diabetes without careful counseling, and they need careful follow-up.
Well, I have another question. I'll start with Dr. Teacup again. Diabetes causing burning in the feet. Why does that happen? Maybe a little bit about neuropathy.
Yeah, I think you're describing there's peripheral neuropathy, and generally it affects the feet. The longest nerves in your body are down into your feet, and so they're usually the first ones that are going to become symptomatic. People describe a burning sensation, a feeling like they're walking on pins and needles. Numbness is another common finding. They believe that over time diabetes ages the nerves basically by higher sugars, and they think it damages nerves over time. Everything with diabetes is accelerated. The aging process is accelerated. So peripheral neuropathy is seen with other conditions, and even age alone can cause peripheral neuropathy. But diabetes brings it about much sooner. And the longer that you have diabetes, the poorer that it's controlled, the higher risk that you have of developing this, which is a major complication and something that really causes a lot of morbidity for diabetic patients.
Dr. Ralston, a caller from Duluth asking about metformin. Are there any problems with long-term use of metformin? Maybe just talk about metformin in general.
Metformin is a fantastic drug, and if possible, all type 2 diabetics really should be on it. So long-term complications, I would say, is not taking it if you're available. Metformin is a great pill. It's a twice-a-day pill generally, sometimes once a day, that actually helps our body become more sensitive to the insulin that we already have. And one of the wonderful things about metformin is that it over time actually reduces our risk of dying from diabetic complications. No matter what it does to your A1C, if you're on metformin, you have a lower risk of dying at an early age, and that's a fantastic reason to be on the medication. Now, the biggest problem with metformin is that it can cause pretty significant upset stomach and GI upset, diarrhea and bloating, and so we have to start at a low dose and kind of let you work up gradually. One of the other nice benefits is that unlike some of our other pills, in general it doesn't drop our sugars too low. So one of the problems we have with treating diabetes is if we get a little too aggressive and your sugars drop too low, called hypoglycemia, you can become very sick and sometimes faint, and it can be a real scary situation. Metformin doesn't do that. Now, if you have kidney problems or if you're on some other medications, your doctor will want to monitor that level and to make sure that you're on the right dose of metformin. But I think it's a great medication, and unless you have kidney or liver problems, I think it's a good idea to consider being on.
If I could add to Dr. Ralston's comment, that the metformin is a great medicine, and because of that, it bothers us at times to see patients that have stopped it, mostly because at least a common cause is the diarrhea. It also does cause, usually if you question the patients, it's typical that they'll have a fatty meal, and that will, metformin decreases the absorption of fat, and that fat goes to the colon and gets turned to water by the bacteria, causing diarrhea. And a lot of people stop metformin because they get diarrhea, and it's very important to try to stay with the metformin, but watch your diet. Fried foods, fatty foods tend to sabotage the metformin and give it kind of a bad name for side effects.
Is there a certain time of day that you should take the metformin? Before meals or after meals, or is it?
Well, there's just a few different formulations, so it kind of depends on which type of metformin you're taking, once a day or twice a day. But mostly, I just want patients to take it.
Excellent, good. Well, Dr. Baldwin, a caller from Hibbing asking about the correlation between high cholesterol and diabetes.
There goes the side effects or the problems that happen when you have diabetes. It's very important to control your cholesterol when you have diabetes, and many times triglycerides in particular will be high when the blood sugar is not well controlled. But the combination of a cholesterol out of control and diabetes increases your risk of heart disease and heart attack tremendously. So that's the reason that we have goals for cholesterol management with diabetic patients, lower goals than with other people who don't have diabetes, shooting for an LDL of at least under 130 if someone has nothing else going on, but preferably under 100. And LDL is the bad actor cholesterol, if you will. Shooting for an HDL of greater than 40 or 45, and that's often achieved mostly with exercise. No particular pills help that. So cholesterol is real important for preventing the complication of heart disease and heart attack that comes with diabetes.
Excellent. Well, Dr. Teacup, a caller from Superior asking about gastric bypass, which I think, is it used as a tool to treat diabetes?
Gastric bypass is a major surgery. It can be used as a tool for weight loss, which often leads to improvements in diabetic control. Gastric bypass, however, is not a surgery to be taken lightly. In Moose Lake, we have done many gastric bypass procedures, And over time, you get experience with the surgery. It's a great surgery if it's done for the right indications. But I think at times we really need to know that people have complications, sometimes long-term complications from gastric bypass. So it's not something we start with. And in fact, most insurance companies and most doctors, there's a whole array of steps that you need to take before you can be considered for gastric bypass. There are other options such as just an intense dietary consultation and exercise fitness evaluation. Then there's also things like the lap band, which is a little less invasive, and I think the surgery, if it's done for the right reasons, can really be a great surgery. If it isn't, it can really be hard for patients. The anatomy does change. It's hard for other doctors to sort out what would be going on in the abdomen after surgery's been performed. And so I wouldn't take it lightly. It's very major surgery.
Oh, that's very helpful. Well, Dr. Ralston, maybe talk a little bit about monitoring blood sugars. I have a caller asking, they check their blood sugar and get one result, and maybe 5 minutes later they may check it again, and it may be 20, 30 points difference.
Yeah. Well, our blood sugar is changing all day long, and I think that it's important to realize that what we're looking for in monitoring and treating our blood sugars is really a pattern. I also think that it's important to realize that how often we monitor blood sugars really depends on what kind of therapy we're on. If you're a type 1 diabetic who is solely dependent on insulin, there's no other treatment for type 1 diabetes. Typically, we recommend checking blood sugar every time before you eat and before bedtime. Oftentimes a fasting blood sugar and at night and with meals. So it's very intense. It's a lot of work whenever you go out to eat or whenever you go on vacation. You're checking your blood sugar at least 4 times a day, and that's really important. Type 2 diabetics who are just on metformin, oftentimes I won't have them checking blood sugars at home, if at all. So it really depends on what type of diabetes and what your therapies are. Mostly I want people to know their trends, their patterns of when their blood sugars tend to be high, or people who are at risk for low blood sugars, I want them to know that as well. The other thing that's important to realize, as you pointed out, blood sugar changes in part based on our stress level. We have hormones in our body that their whole job is to increase our blood sugar. It depends a little bit on what kind of exercise you've done lately or when you've eaten last. Many people are surprised when they wake up in the morning and have high blood sugar, and that's very common. Our liver stores sugar so that we can go long periods of time without food and keep our blood sugars okay. And in the morning time, we do have a surge of this stress hormone called cortisol, which increases our blood sugar. So I don't want patients to chase after blood sugars all day long. I want them to understand their own trends and their own patterns so that we can adjust insulin gradually or their pills.
Well, Dr. Baldwin, this is an interesting question from Moose Lake. Correlation between diabetes and developing pancreatic cancer or abnormalities of the pancreas?
Well, I don't know about the correlation between diabetes and the development of pancreatic cancer. I know that people who have diabetes, eventually their ability to form insulin, for some people with type 2 diabetes, their pancreas can eventually basically fail. It's not making enough insulin that they can manage with pills. So then we'll resort to using insulin with people who have type 2 diabetes as well. But in terms of, I really don't know if there is a correlation between the development of pancreatic cancer and diabetes.
And I think one of the interesting things is the pancreas really has a few different functions, and it's phenomenal at separating those functions. So people, for example, who get pancreatitis, an inflammation of their pancreas, they very rarely have problems with diabetes as a result, sometimes in severe cases, but our pancreas can maintain that diabetic function. They're different cells of the pancreas, and the type of cells that generally get cancerous are not the type of cells that generally produce insulin. So it's almost like 2 different organs in one.
I thought it was an interesting question. This is about Januvia. Dr. Teacup, if you want to take this one. Januvia's effects in diabetes, and or if you want to spin off on other medications that we use for diabetes.
Januvia's effects on diabetes. Yeah. There's lots of these new medications that have come out. Januvia, I think, has been out about 2 years, maybe 3, somewhere in there.
Somewhere in there, yeah.
And I'll let you pick up on that if you want. It's a DPP4, I believe.
Yeah, so
And,
some people know this one as the lizard spit one. Januvia and Byetta are the newer ones, and it's really a matter of trying to make our bodies produce more of the insulin. It's kind of a nudge to the pancreas to say, wake up and produce a little more insulin when you need it to. And we have these enzymes that break down insulin, and Januvia helps block that enzyme so that the insulin that you have stays around a little longer. Januvia is a pill form. It can actually have some problems with it, and it's a great medication, but actually if you look at the amount that it benefits your sugar, compared to some of our more old-fashioned drugs, it maybe will drop your A1C by 0.6 to 0.8. And that's a lot lower than even starting a diet or exercise program. So it's not one that I use as a first-line therapy generally. And again, these are all for type 2 diabetes.
I'll give you a little bit better one, Dr. Teacup.
Oh, that's
Both parents, if you have both parents and they have become diabetic in your family history, is there a higher likelihood that you'll develop diabetes?
Yeah, absolutely. And I think the correlations are if it's type 1 diabetes, the risk is higher than if it's type 2. There's always a genetic component and it's hereditary. Because of that, you are at higher risk, but not guaranteed. And I think that most people can prevent type 2 diabetes with the right kind of goals if they put themselves out for it.
Dr. Baldwin, asking about immunizations. Are there immunizations that patients who have diabetes we should make sure that they have?
Well, I pretty much like adults to get the flu vaccine regardless of whether they have diabetes or not. Sometimes we'll immunize for some of the chronic diseases earlier if someone has diabetes. So for instance, I'll often suggest pneumovax earlier in someone with chronic disease like diabetes. Beyond that, I guess I don't have any other immunizations that I particularly suggest, different than other adults.
Pretty much standard things that we like to have, a little bit more risk. Dr. Ralston, a caller asking about, sometimes I eat a large quantity of sugary candy and my blood sugar doesn't change. Any reason that it's not changing?
Because insulin is doing its job. Yeah, that would indicate that they're a type 2 diabetic and your body is still producing insulin. It may not be quite as effective as it used to be. It may not always be quite enough, but it means that you do still have the system in place and it's doing its work.
Okay, Dr. Teacup, if we have a caller asking about screening for diabetes, what kind of screening test do we do? A hemoglobin A1C or a fasting sugar?
Right. I think whenever someone comes in, I mean, we're constantly screening our patients for diabetes, whether they come in for it or not. It just has too many complications to miss and too many valuable things to prevent. So we take the history. We ask patients about symptoms that they might have. I know Dr. Baldwin had mentioned drinking a lot of fluid, eating foods, constantly eating. We look at stratifying the risk. If they're overweight, they have a higher risk. Those types of things. When it comes down to after the history and then the physical exam, there are certain things on physical exam that can indicate diabetes. Things like central obesity, we see patients that actually have neuropathy or decreased nerve function, particularly of their feet. Some don't feel the sores that they have on their feet, and we still see that kind of diabetes present itself this late in the game. After the history and the physical exam, most of our patients do come in fasting, and then at that point we'll do a fasting blood glucose, and levels of 126 would indicate diabetes, type 2 diabetes. And then from there, we often would then move toward A1Cs, hemoglobin A1Cs, which can help us to determine or at least confirm the fact that they've had high sugars for quite some time and what their average sugar has been over the 3 months. So those are some of the screening tests that we do. We also, though, screen for problems with the kidneys. We look at kidney function, and we also do urine testing, looking for leaking of the kidneys with protein, things that diabetes injures. We can pick that up through through lab tests.
And then we monitor patients on a frequent basis.
Sure,
See
and
them
you never want to go by just one lab test. It's a combination of history, physical, multiple lab tests that help us confirm the diagnosis. If someone has active symptoms of diabetes, like we had mentioned previously, and their sugars are over 200, we can basically at that point clinically diagnose the diabetes, type 2 diabetes.
Good.
We often detect type 1 diabetes. Working in the emergency room, that's where we'll detect type 1 diabetes in the form of what they call DKA, or diabetic ketoacidosis. And those patients often come in with symptoms that mimic the flu, throwing up, diarrhea, often in kids. And we really have to be careful. It's easy to miss high glucose levels.
Well, thank you very much. Our time is out. So I want to thank our panelists, Dr. Gail Baldwin, Dr. Deborah Ralston, and Dr. Steve Teacup, and our medical students, Daniela Vasseur, Jessica Olin, and Isaac Zoller. Please join Dr. Ray Christensen for a program next week on arthritis, when his panelists will once again include Dr. Gail Baldwin, along with Dr. Rostam Khan and Dr. Chris Thiessen. Thank you for watching. Good night.